can start.
Assalamu alaikum, good morning, and welcome to the third day of Kuwait Family Medicine Review course. Inshallah, we will start our first lecture, which is Urgent Care with Dr. Sara AlHammouri. Dr. Sara is specialist family physician in Khalid Al Ghunaim Medical Center and trainer in Kuwaiti Board of Family Medicine. Also, she is head of Emergency Program Committee of the Primary Care. حياك الله دكتورة سارة.
الله يحييك دكتور. صوتي واضح؟
أي واضح.
Okay, so we can start. السلام عليكم, بسم الله الرحمن الرحيم, وصبحكم الله بالخير. Thank you so much for everyone who's attending today. I know everyone prefers to be in bed now by 9 or having a breakfast with their family, but thank you so much. I appreciate your attendance. I'll take the opportunity to thank all the organizing committee for inviting me to be a participant as a speaker in this review course, which is the 8th review course, which I'm so proud of. Since Wallah alhamd, I had بفضل الله سبحانه وتعالى the opportunity to be with my colleagues Dr. Sara AlHammouri and Dr. Lulu Al-Asousi, the founder of this review course in 2016, and I'm really happy and proud, and since that time now it's the 8th, it has been continuously progressing, amazing scientific event every year, and all residents are keen and eager to organize it in an even better way than the year before. So thank you so much for this opportunity. I'm really happy to be with you today, and I hope that the lecture will be, although it's a little bit condensed, but I hope it will be light and you will get some benefit from it. So Bismillah ar-Rahman ar-Rahim, today we'll talk about urgent care and primary care. And we know, all of us, that we are encountering a lot of emergency cases. And to manage those cases well, we have to have few things in mind. So as an introduction, we will talk in this introduction about the general approach to emergency cases, the ABCDE assessment, the Glasgow-Coma scale, and the recovery position. Then we will talk about different systems and different scenarios and cases that we will encounter in those specific systems. So safety. Dealing with emergencies and dealing with any case in general, like it is around safety. And safety is very, very important in cases of emergency, because being a safe doctor will preserve your safety, the patient's safety, and safety of the practice. So to be a safe doctor or to practice safely, you need to have a proper knowledge, you have to have good applied knowledge, and you have to have some skills to apply those knowledge appropriately. So this will help you get into a proper provisional diagnosis. You'll be able to stabilize the patient properly and start initial management and send the patient to the emergency room in a timely manner for further assessment and management. Of course, this will not be done like instantly. It needs practice, needs knowledge, needs reading, practicing a lot of cases, practicing a lot of emergency rooms. So my advice to you is just go and throw yourself in emergency cases. Try to manage as much as possible, because in this way you will be able to gain and build those skills. So be calm and reassuring. I'm sure most of you, when you are reading for the exam or preparing for your daily exam, which is daily work, you will always find this word, be calm and reassuring, at any management plan of dealing with any emergency. So why is that? Why it's important? Let's talk about briefly the physiology of that. In any stressful event, and we are sure that an emergency is a stressful event or a stressful situation we as doctors are being in, as well as our patient. So in this stressful event, the survival mode will be on in our body, and the fight and flight system will be also activated. This will produce high cortisol level in our body, which will cause slow critical thinking, or slower the critical thinking and executive function by affecting the prefrontal cortex. The amygdala, which is the area in the brain responsible for the fight and flight and emotions, will get larger and takes over. while the hippocampus, which is the area in our brain concerned about the learning and memory, will temporarily narrows. And of course, this will affect our judgment and decision making. So trying to be calm, trying to be reassuring to ourselves and to our patient will help a lot in our decision making and in dealing properly with our emergency cases. And I'm sure it's not easy. Again, it needs a lot of practice and skills and knowledge. But there are things that we can do that will help us be more calm and reassuring, like calling for help in a timely manner, for example. All of you in your clinic, you have an emergency team where you can call and refer to whenever you are encountering an emergency. So don't hesitate, even if you are a senior, a specialist, a consultant, having another person, excuse me, there's a voice around, I can hear some voice. So asking for help will make the emergency case being more smooth, and you will be more relaxed with dealing with the emergency. Of course, you should not be so relaxed, but at least you will be relaxed to an extent that you will manage the emergency in a proper way. I always say 2 brains better than 1, 4 eyes better than 2. They will see things that you cannot see, and they will think of things that you will not think of. Sometimes even the nurse will provide a proper help and will remind you of things that you may miss because of a lot of things that you have to keep in mind while dealing with this emergency. So don't hesitate to call for help, regardless of your level. The other point is that may help you being calm more and reassuring is when the ambulance come early. So calling the ambulance early with a proper early assessment and decision of calling the ambulance will help a lot in an arrival of the ambulance early and transfer early to the hospital for further assessment. So always keep in mind that you should call the ambulance. Don't hesitate or don't delay the call for the ambulance. So we became now calm and reassuring. Now we have to do the proper work, which is we'll start with the ABCDE, which is the approach that we have to use with every emergency case. So, of course, all of you know that ABCD refers to airway, breathing, circulation, disability, and exposure, but we won't like to have in details what is each and every one of them refers to or means and how we can approach it. For the airway, if the patient can talk, it means the airways are patent. If they are not able to talk, it means we have to open the mouth, look if there is anything obvious object or something compromising the airway, and we can remove it, like, for example, secretions by doing suction. Breathing, look for use of accessory muscle, diminished breath sounds, added sound, cyanosis. We have to check for respiratory rate, oxygen saturation, which should be between 88 and 92 for a COPD patient, and 94 and 98 for other persons that don't have COPD. In the circulation, we'll check pulses, peripheries, which is like we can see if they are warm, cold, or cyanosed. Capillary refill, which is ideally should be below 2 seconds. Insert an IV cannula, and always in emergency cases, especially critical cases, it's advisable that you insert 2 large bore cannulas at the same time, because you don't know what will happen later and if you will find a vein later or not. Disabilities, you will check for the Glasgow Coma Scale that we'll talk about in a minute, and we will see the level of consciousness of the patient. Exposure, sometimes you have to expose the patient fully, or sometimes you have to expose the patient in certain areas to look for anything that will help you in the management, like, for example, stings or bites, or you can find injection sites. So, but always keep in mind that dignity should be preserved while exposing the patient, because like, put yourself on the shoes of the patient. If you have been in an emergency case, all of you, you don't want anyone to expose you or without like preserving your dignity and closing the curtain or closing the door and avoiding anyone like there, like some relatives or any like extra people in the emergency room that are not necessary to be there. And of course, those slides, I'm using the slides of the primary directorate, so you can just keep it in mind and be familiar with, because it should be stuck or posted in your emergency rooms in all the clinics. So if it's not there, I advise you to go to your trainers, go to your head of clinics and ask them to put them in the emergency room handy so you can refer to them fast. So what is the Glasgow Coma Scale? As we have mentioned, it is a scale that we can use to assess the disability of the patient. It consists of 3 components: the eye opening, verbal response and motor. Usually I remember it like in order: eye, motor, and eye, speech, and motor, or verbal and motor. The lowest score will be 3 out of 15. So never, never, ever write in the referral letter that the Glasgow Coma Scale is 0/15, even if the patient is unconscious at all. Then we will assess according to the response of the patient. Like, for example, if he's spontaneously opening his eyes, oriented to time, place, and person, and obeying commands, it means he's getting 15 out of 15. And accordingly, you will assess the other scales or other scores. Just keep in mind that we don't use the Glasgow Coma Scale a lot. So we are prone to forget it. So just keep in mind that if you are not having it on the wall of your clinic or the emergency room, just keep it in your bucket, just in case you need it, because it will help a lot in the management. For example, if you see a patient whose Glasgow Coma Scale now is 15, and then he went to the emergency room and he deteriorates on the trip or on the road to the emergency room, this will help the doctor there to find that there was a deterioration of the level of consciousness, and will help in the management and the speed of applying the medications or giving the medications and management. So don't underestimate your Glasgow Coma Scale assessment at the beginning of the emergency, dealing with the emergency at the beginning. Recovery position, it's the position that we put the patient in, and usually you hear it a lot, which is sometimes used if the patient is unconscious, but they have circulation and they are breathing. So it means they are not a patient or a candidate for CPR. So we can turn the patient to the lateral position, and I will show you a picture in a while. The purpose of this position, it's very helpful in cases where the patient is prone to vomiting, for example, or they are prone to having airway obstruction for any reason. So they will maintain good airway, ensure the tongue does not cause obstruction, and minimize the risk of inhalation of gastric contents. So this is a picture showing the steps of putting the patient in recovery position. You can also refer to YouTube and see a lot of videos about how to put the patient in recovery position, because some patients are heavy, that you need like 2 people or 3 even to help you in putting the patient in recovery position. So it's very important and very beneficial to know by now how to use it, because in situations where they are dealing with an emergency, it will be a little bit more difficult. So this was the introduction for the presentation. Now I'll go into the main emergencies that we'll discuss, and we'll start with the cardiovascular system. In the cardiovascular system, we will talk about the 3 main emergencies that we most commonly get encountered in primary care, which are heart failure, myocardial infarction, and hypertensive emergencies and urgencies. Of course, there are a lot of other cardiovascular emergencies such as cardiac arrhythmias, deep vein thrombosis, pulmonary embolism, cardiac arrest, and bleeding, which are important to know how to deal with them, but we will talk about the most common now. So we'll start with a case scenario. SM is a 68-year-old lady known to have type 2 diabetes, hypertension, ischemic heart disease, and asthma, presented with her son for progressively increasing shortness of breath for the first time. Her vital signs are as you can see: normal blood pressure, normal heart rate, normal respiratory rate. Chest examination in the country showed normal breath sound, but there are basic crepitation bilaterally, and there is some lower limb edema, but the abdomen is soft and lax with no organomegalies, and the heart sounds are felt or are heard normally with no added sounds. So we have a lot of key things we have to take from this scenario: that the patient is an elderly, she has multi-medical issues, including which are with high cardiovascular risk, like type 2 diabetes, hypertension, ischemic heart disease, and also asthma. She's having this new presentation of progressively increasing shortness of breath within few days. So all her vital signs are okay. There is lower limb edema, there is basal crepitation. So I think now you all have this high suspicion of left ventricular hypertrophy, left ventricular failure. The other case is a KH, a 56-year-old gentleman smoker known to have uncontrolled hypertension, not on any proper follow-up, presented with shortness of breath, chest pain, lasted for 15 minutes, and associated with nausea. So he has also, besides a very high blood pressure, 180/100, heart rate is 50, respiratory rate is 20, chest examination, there was a scattered wheeze with basal crepitation also, and the S1, S2, and S3 was here. lower limb edema also there, it was presented, and there was some abdominal distension. So he had all the features of heart failure, plus he has a chest pain and high blood pressure. So it could be like very severe hypertension, causes hypertensive emergency and heart failure, and am I يعني unlucky person. So we have to deal with all of these things in such situation, and throughout the lectures we will know how to deal with them. So I'm sure by now you know that we are talking about acute left ventricular failure or heart failure. It has a lot of symptoms that I'm not going to go through all of them, but you all know that shortness of breath, orthopnea, PND, cough with sputum production are the most common. Then we will look for signs of lower limb edema, gallop rhythm, basic crepitation, and ECG findings will be there, may be indicating MI or left ventricular hypertrophy. We have to keep differential diagnosis in our mind, like PE, asthma exacerbation, and pneumonia, and we should not like do premature closure once we are encountering a heart failure case. So what is the approach for management? I always try to remember this way, is by like if I have asthma, I remember what are the medications for asthma. If I have heart failure, I remember what are the medications for heart failure, then I will apply it, because as we all know, we need knowledge and we need applied knowledge. So the knowledge that we need to know in heart failure management is oxygen, position, furosemide, GTN. So those 4 things. And of course, referral and calling ambulance. So how we are going to order, like to have them in order, we'll talk about this, but I'll just mention that the GTN role in heart failure is like, we always say GTN for heart failure, but if we want to know what is the role exactly, it will dilate the systemic veins and increase the capacitance of the vessels and reducing the venous return to the heart, and thereby lowering the ventricular filling and preload. And this is the role of the GTN in heart failure. And furosemide, of course, we know it's a diuretic that will decrease the fluid overload in case of heart failure. So always refer for admission if, of course, in our situation, we will refer most of our patients to the secondary care for further assessment and management if we are suspecting heart failure, or we are sure that this is a patient coming with known heart failure but with deteriorating symptoms. But there are situations it's mandatory to refer if the patient is alone at home and or inadequate social support is there. If you are suspecting a cause of acute left ventricular failure that warrants admission, like acute MI, if the patient is very breathless and no improvement regardless of whatever management you have done, or he already took at home, or if the patient is hypotensive or having any arrhythmias. So this is the diagram of the acute left ventricular failure, just to keep your eyes familiar with it. So be calm and reassuring again, and we know why now it's important to be so. Call ambulance in a timely manner, put the position of the patient, put the patient in the upright position, and then start treatment by giving oxygen, of course, because with heart failure, the patient will be desaturating. So oxygen, maintaining saturation between 94 and 98, and for COPD patient for 88 and 92, give GTN, and we all know now why the GTN is important in heart failure, and the dose would be, as I will mention in the other slides, fix an IV line and give a furosemide, of course, to restrict IV fluids. Now the furosemide is sometimes an area for debate, because some of the doctors are a little bit hesitant to give the furosemides, especially if the patient is hypertensive, coming with hypertension and heart failure. They will say, if I give the furosemide, the blood pressure will go low, and I may complicate the case and may do some consequences or worse consequences to the patients. Just make sure that this dose, the 20 to 50 milligram of furosemide in a overloaded patient, fluid overloaded patient, will not, inshallah, cause any bad consequences or complications. And if you are in doubt, give the lowest effective dose, which is 20 milligram. But at least give something, give a treatment, give the patient the treatment that would relieve their symptoms, because the patients will come breathless due to heart failure. They will feel that they are going to die. So you need to give them something to relieve their symptoms. So don't hesitate to give it. It's inshallah safe. And always, again, ask for help, to have another opinion, and to help you in taking the decision if you are in doubt. So, and of course, just one point to mention, that all of the things that we are mentioning are applied for the exam sakes. So I'm telling you things that will help you in both the daily exam, and which is the daily exam in your clinic, and the exam, inshallah, that you will all pass inshallah, soon. Okay, so there are special situations when dealing with heart failure, like asthma patient. Don't forget that if the patient is asthmatic, just to consider the diagnosis, and if he is labeled as asthma to have asthma, just keep in mind if he's an elderly, he has multiple medical issues. If there is edema, if there is cough with sputum, especially bloody sputum, if there is basal crepitation, so it takes us away from the asthma diagnosis and think of heart failure or other differential. Myocardial infarction, of course, we all know that they may come together. So don't forget the chest pain and ignore it. Just treat it. And alhamdulillah, the GTN is the treatment for both. Hypertension, of course, if the patient is having very high blood pressure, again, here the question of furosemide, give the lowest dose if you are not sure. Anemia, just keep it in mind once you are encountering a young lady. For example, we are a lot seeing this situation or this scenario of a young housebreaker who is coming with like bleeding for whatever reason, and she's having severe anemia. If so, and you request an urgent CBC and you find a hemoglobin of 4 or 5 or 6, just keep in mind that heart failure may develop if it was a prolonged anemia that we don't know from where or from how long. So just rule out the signs and symptoms of heart failure and do an ECG. Morphine, in the past, it was part of the management of heart failure. Now all evidence showed that it will worsen the clinical outcome, so it is removed from the management of heart failure. IV fluids, of course, should be restricted in dealing with heart failure. So now we'll see another scenario. NJ is a 60-year-old Kuwaiti lady known to have hypertension, presented to your clinic on a wheelchair, complaining of chest pain on exertion lasting for 30 minutes, associated with nausea and vomiting. Her blood pressure was 200 over 120. Her saturation was maintained and heart rate was okay, while the respiratory rate was 15 also, which was normal. So we all see, we can like get from this that she's 60, hypertensive, coming to on a wheelchair, which is like an alarming feature. She's having a chest pain on exertion lasting for 30 minutes, which means a typical chest pain with nausea and vomiting. So definitely we'll take the patient to the emergency room, do the vital signs and start management because she may have acute coronary syndrome. Another scenario of a younger person who's 37 years old, presented to, he's known to be a heavy smoker, presented due to the chest pain 5 hours ago while he was playing football with his friends. So the thing is that the chest pain could be now, and the patient is actively coming with a chest pain, or they may present with a typical chest pain that presented few hours back, and alhamdulillah, it passed. Nothing happened at that time, but he's coming to us telling us that he had this pain like few hours ago. So take it seriously, even if the patient is young, because as you can see, he's a smoker and a heavy smoker, and also he may have hyperlipidemia that we don't know about. So ask about premature cardiovascular diseases, premature deaths in the family, because those will make the patient at high risk of developing cardiovascular diseases. His vital signs were fine, but we cannot rule out acute coronary syndrome, so we will do ECG and we will continue management accordingly. So acute myocardial infarction, it's the presence of acute injury detected by abnormal cardiac biomarkers in the setting of evidence of acute myocardial ischemia. We have the term acute coronary syndrome, which consists of two main categories: a category with elevated troponin in case of non-STEMI and STEMI, or without elevated troponin, which is unstable angina. So now unstable angina is part of acute coronary syndrome label. So what are the management that we will provide for a patient with acute coronary syndrome? Of course, we will call ambulance. We will do the vital signs. We will do ECG to confirm the diagnosis, but sometimes could be normal, which will not exclude the diagnosis of acute coronary syndrome if we are having high index of suspicion by history and examination. So we will start oxygen if required, if the saturation is below 94, not for every single patient. So we will always have to know what is the saturation before giving the order of oxygen, because it has nothing to do with the outcome if it is maintained. Sublingual GTN, 300 to 400 microgram, can be given 3 times, 5 minutes apart. So we will repeat it. We will give it once, twice, and 3 times if the pain does not resolve. Of course, there are some contraindications for GTN that we should know and keep in mind. If the patient is hypotensive with a systolic blood pressure below 90, heart rate more than 110 or below 60, if there is inferior MI in the ECG, or the patient is dehydrated, so there are signs of dehydration which indicates it may be inferior MI, or if the patient is on phosphodiesterase or like sildenafil, for example. So in those situations, within the last 24 hours, of course, taken. So in those situations, it's better to avoid giving a GTN. Also, if there is allergy to GTN, known allergy. Another management point or another management medication is the aspirin, 300 milligram oral or chewable, if not contraindicated. So now the IV or IM morphine, the dose will be 5 to 10 milligrams stat, and we will see now when we'll give it. If there is respiratory depression due to morphine, we have to have the antidote, which is naloxone, with a dose of 0.4 to 2 milligram. Metoclopramide sometimes given because the morphine may cause nausea, so we may give it together with the morphine if we require. And if there's bradycardia, we should consider the atropine IV 500 microgram. So all of these medications, remember putting all the medications, so just keep it in mind in case of MI. So there are special situations that we have to consider. If the patient is diabetic, it means the patient will come with atypical chest pain or with a silent MI. So they will present with sweating only, no chest pain, have high index of suspicion in such situation. Or the patient will tell you that I'm always, when I walk or when I sit in a place and the weather is fine, I feel sweaty. Or they will tell you that I have some like نقزات يقولون, and like some pain a little bit and they cannot explain how is it exactly. Consider it serious and do ECG and do all your workup. Young and smokers have a high index of suspicion. Now, morphine for the pain, it is used if unacceptable persistent discomfort for anxiety and for anxiety related to MI, but it should be given if the pain is unacceptable and GTN was given 3 times and still there is no response to the pain, we can then go to morphine. Before giving the morphine, if you gave GTN once, twice, and 3 times, and the patient is still not having improvement of his pain, just assess your diagnosis. Make sure, is it a real MI or is it a real acute coronary syndrome, or there is another underlying problem for this chest pain. So if you are still sure, you can give the morphine at this situation. Why is that? Why we are like postponing the morphine? Because all evidence showed, retrospective studies suggests that its use is associated with an adverse effect on outcome. So it's better to avoid it or better to keep it for like a fourth option, not the first line option. So so this is for MI and acute coronary syndrome. We knew the management, and we'll go now to hypertensive emergency and urgency, which is the third topic that we'll talk about in cardiovascular emergencies. Difference between hypertensive urgency and emergency, I'm sure all of you know by now that the blood pressure above 180 or 120 diastolic, if it is with end organ damage, or as it is called in the new guidelines, hypertension mediated organ damage, if the hypertension mediated organ damage are available, it means this is hypertensive emergency. If there is no hypertensive mediated organ damage, it means this is hypertensive urgency. Why do we have to know the difference? Because management, of course, will differ. So what are the end organ damage that we should keep in mind? Those are the list of it. It will affect every organ: brain, stroke, visual disturbances, papilledema, oliguria, acute kidney injury, chest pain, myocardial infarction or aortic dissection, dyspnea or orthopnea PND may cause pulmonary edema or heart failure, nausea and vomiting, increase intracranial pressure. In pregnancy, it may cause eclampsia and acute severe back pain, which may suspect aortic dissection due to this high blood pressure. So we should rule out those by history and examination and the available investigations that we have. So what are the investigations that we can do in the clinic? Of course, after history and examination with high index of suspicion, we have to do an ECG. We may do a urine analysis to look for proteinuria or blood in urine. And we can do, like, if we have the lab and it's available in the morning, we can like ask for urgent renal failure, which is not practical in fact. So we will stick to the urine analysis and the ECG and fundus examination. I know most of us are not like familiar with the fundus examination by the fundoscope that we have in the clinic, or that you should have as a doctor, and you should have it in your clinic. So please try to practice it. Practice doing it, because you don't know, you may save the patient's eyes and this patient's life from like a simple examination that you will use to while doing it regularly. And of course, I know that it's difficult to use, it needs dilatation of pupil, but let's try to do so because maybe it will be helpful. Then Do we have to refer all patients with hypertensive urgency to do all the investigations required to make sure and to swear that this is hypertensive urgency? It depends. Not all patients, but if you are in doubt, you are not sure, you don't have the facilities, you have high index of suspicion that this patient, you are not comfortable with this patient, just be safe and refer this patient for further assessment and to rule out secondary causes. I mean, rule out end organ damages. Okay, so the management of hypertensive emergency, as you can see, or urgency, it will be that we have two arms. If there is end organ damage, the thing that we will not give anything for the blood pressure, we will not reduce the blood pressure, and we will mention the reason in a while, but we will stabilize the patient and manage whatever there. For example, if there is MI with the heart failure, there is chest pain, we will treat the chest pain. We will give GTN. We will give aspirin, but we will not reduce the blood pressure by any medication. So just keep in mind that you will not ignore, when we say don't give anything for hypertensive emergency, it doesn't mean we will keep the patient like this and we will wait and look at the patient without giving anything. There is another problem. We will try to manage the other problem. Or there is associated problem, we will try to solve or to treat the associated problem within the facilities we have. While in hypertensive urgency, we have two scenarios. If the patient is known to have high blood pressure and he's already on medication, we should assess his compliance. We should reintroduce his medication if it wasn't taken. We should give him adjustment of his medication and give him a very close follow-up. If the patient is not known to have hypertension before, of course, the preferred option and the better option to do is to start right away with a long-acting antihypertensive medication after, of course, putting the patient in a quiet room and remeasure the blood pressure again. So there is the option always arising, which is the captopril, giving the captopril, of course, orally, not sublingually. I'm sure all of you by now know that. Do we give it or not? It is, if you read up to date, you will find it it's still there in up to date to give captopril if required. But even in up to date, it was mentioned that the preferred option is to give a long-acting antihypertensive medication. So just don't hesitate to start the long-acting antihypertensive medication, and we will mention now why. And for all patients, give a close follow-up in the clinic later on. So what are the dilemmas in hypertensive emergencies management? Should we refer the patient for all the tests if we could not find any end organ damage? Again, high index of suspicion, not sure, you don't know, refer. Should we use oral captopril? Okay, so to answer this question, we have to know why we are using the oral captopril. It's a short-acting antihypertensive medication that will reduce the blood pressure fast, and we will give a very low dose, 12.5, which is half the 25 tablets. So it's not going to reduce it very fast, but it will reduce it a little bit. So do we need to reduce it? That's the question. Do we need to reduce the blood pressure while the patient is in our setting within half an hour? Do we have to reduce it? Evidence showed that the blood pressure should be reduced over a period of hours to days, so not within half an hour. Although slower reduction may be needed in older adults, patients at high risk of cerebral or myocardial ischemia resulting from excessively rapid reduction of blood pressure. In addition, moving patients to a quiet room to rest can lead to a fall in systolic blood pressure by 10 to 20 millimeter mercury or more. So don't underestimate this step in the management of hypertension. So what is the blood pressure target during this time period? We want to reduce it by up to 160/100, but like this will happen within the 4 hours, the coming 4 hours, not right now, not within 20 or 30 minutes. So again, captopril, is it important? Do we have to reduce it now within 20 minutes or 30 minutes? It's your choice. It's in the guidelines. I cannot say it's wrong, but there is a preferred, better option. Also in the European guidelines now, the new guideline, it was mentioned that you have to give a long-acting antihypertensive medications in such situations. So why is it recommended to reduce the blood pressure slowly over several hours to days? Because we have to maintain a balance between the autoregulation that happened with this high blood pressure, severe high blood pressure. The body will have an autoregulation to perfuse the organs. So this will keep working, the autoregulation, And then we have this very high blood pressure, which may affect the perfusion to the heart, to the organs, to all the organs. So we want to make this balance between this autoregulation that is doing a good job and this very high blood pressure, which is doing a bad job, and not reducing it fast to affect this autoregulation. So reducing it slowly will make a balance between the two, and we will get the proper perfusion to the organs, and inshallah, the patient will survive. So this is a nice picture. I have taken it from Google. It's for an area that we all pray for nowadays. It is from Palestine. So just to clean our vision. Okay, so now we'll go to the respiratory system. So when talking about the respiratory system, we'll talk about asthma and croup and anaphylaxis. So asthma, I will not discuss all those points of asthma because this is from Gina, you can all refer to and read. I will give you like take-home messages. So whenever you are encountering an asthma exacerbation, first you have to assess the severity properly because the severity will affect your management. Then keep in mind that salbutamol, short-acting beta agonist, is the treatment of like choice in this situation, and you can give repeated dosage. The dose we are now recommending a inhaler with spacer, and sometimes nebulizer, especially from severe exacerbations and above, because from severe, mainly the oxygen saturation will be reduced and we will need oxygen-driven nebulization. So the dose will be 4 to 10 puffs by meter dose inhaler with spacer. We can repeat it every 20 minutes for 1 hour. And we can use nebulized, as we mentioned, if we need oxygen-driven nebulization. And also we can use repeat it every 20 minutes interval for the first hour. Early addition of oral corticosteroids is important. So keep in mind that we will give the oral corticosteroid, and oral is preferred to the IM or IV glucocorticoids like the hydrocortisone. So the preferred dose is the prednisolone, 40 to 60 mg, and then we will continue for 5 to 7 days later after discharge. We have to keep in mind that supplemental oxygen is sometimes needed if the saturation is not maintained. And do not forget to adjust medication or start inhaled steroids with long-acting beta agonists according to the patient before discharging the patient. Okay, so acute asthma exacerbation, this is the diagram that you will find in your clinics. You can go through it with all the dosage and inhaled or nebulized. With the percentage and the concentration of all of the medications, and when to start the ipratropium bromide, which is, as we mentioned, the ipratropium bromide will be introduced from severe exacerbations and above. Of course, it's not wrong to give it to a moderate exacerbation if the patient needs, but the place of it in the guidelines is from severe and above because it's where the place we need more bronchodilation. So what are the dilemmas in asthma management? Pulmicort is used in acute exacerbation. Up to now, there are no evidence supporting this practice, but I have read some data saying that maybe in the future it will be added as one of the management of acute exacerbations. But for now, there are no evidence supporting this practice. No evidence of higher dosage of corticosteroids more than 100 milligram IV of hydrocortisone. Then there's a question arising always, is it better to give hydrocortisone intravenously or intramuscularly? Almost there is no difference, but it was the evidence showed that the action is slower for the IM or IV than the oral. So it's preferred to give the oral prednisolone than the IM or IV hydrocortisone. So croup, which is laryngotracheitis, it's a parainfluenza virus infection. It happens in children between the age of 6 months to 3 years, and usually it causes an inflammation of the larynx and subglottic area, causing obstruction and like cough, and usually preceded by coryzal symptoms, runny nose, fever of the child feeling like unwell. Then he will develop this barking cough. So the management will be after categorizing the patient or stratifying the severity of the patient to mild, moderate, severe, or impending or life-threatening respiratory failure. The management will be 3 medications, 3 mainstay of medications. It's either or, not all of them. So either dexamethasone, which is the first line and preferred dose, the preferred medication, 0.15 mg per kg, single dose. Or you will find in some literature it's 0.6 mg According to NICE, there is no difference between the effect of the 0.15 and 0.6, so they chose the 0.15 for a less concentration, but the same effect. Prednisolone, 1 mg per kg single dose, or we can give nebulized budesonide at 2 milligram single dose nebulization. So this is, of course, for mild and moderate. If it is severe, we'll call ambulance. We will give all those medication, one of those medications, and we refer the patient to the emergency because they will give nebulized epinephrine, which needs cardiac monitoring for 4 to 6 hours after giving the patient this medication. That's why we don't give it in our clinic. So anaphylaxis and angioedema allergic reaction, we have to know the difference between the three of them. So the anaphylaxis, the patient will come with angioedema and allergic reaction sometimes with systemic manifestations. The patient will be hemodynamically unstable, may have abdominal pain, respiratory compression, and other symptoms, as you can see. But angioedema, only with angioedema, allergic reaction only with skin rash. So an anaphylaxis may come with all of the above. So in angioedema and allergic reaction, the patient is prone to develop anaphylaxis. So we have to be very cautious in dealing with such cases because at any time they may develop into anaphylaxis and will not discharge the patient unless we are making sure that he's fine and going home with proper treatment and safety netting that if anything deteriorates or anything developed, you have to come back to us. A lot of causes, as we know, it can be food, drugs, insect bites, or latex, for example. So what is the management? Keep in mind IV fluids, normal saline, oxygen, epinephrine, salbutamol if there is a bronchospasm not improved by epinephrine, and glucagon if the patient is on a beta blocker, so the epinephrine will not work well. So there are no contraindication for epinephrine in the setting of anaphylaxis. In the past, the guidelines were towards that they simultaneously give the epinephrine, give the hydrocortisone, and give the antihistamine together. Now, the antihistamine and hydrocortisone from 2021 until now, the evidence showed that the first line treatment, once, twice, and third times, you will give 1 dose, second dose, and third dose of adrenaline. If no response, and while giving this, and you are giving the mainstay of treatment, you can give as adjuvant treatment the hydrocortisone and the peritone or the antihistamine. Okay, of course you know how to give it, where to give it. It's very important regarding the epinephrine, and you have to know the dose, which is 1 in 1,000, and you will give the 1 in 1,000 dose, which is available in all our clinics. So this is the shift in the guidelines between the epinephrine with simultaneous treatment of antihistamine and hydrocortisone, and the shift into making them an adjuvant therapy after the epinephrine. This is also another nice picture to clean our vision again from Palestine also. So we'll go now to neurological emergencies. We'll talk about two main things, which is the TIA and stroke. So TIA versus stroke, we have to differentiate between the two. So in TIA, the patient will come to us and tell us that I had few minutes, a few hours, a few days ago, an attack of, for example, neurological deficit. Excuse me. Okay. And will tell us about those symptoms. And in examination findings, we may find nothing in TIA. While in stroke, the patient will come with active neurological deficit that we have to make sure that this is a stroke or other differential diagnosis. So keep in mind the aspirin. Are we going to give it or not? We will say this in a while. And when to refer the TIA and how. So I'll skip the scenario. Okay. So transient ischemic attack, it's usually the definitions is like a sudden onset of focal neurological symptoms and or signs lasting less than 24 hours brought on by a transient decrease in blood flow. However, this has now changed as it is recognized that even a short period of ischemia can result in pathological changes to the brain. Therefore, a new tissue-based definition is now used. This is going to change anything regarding our practice? Usually not. If you have high index of suspicion, you ruled out differential diagnosis like seizures, migraine with aura, syncope, demyelination, metabolic causes, electrolyte imbalance, for example, or hypoglycemia, head trauma, then this is TIA and treat it accordingly. So assessment and referral, of course, we have to assess the patient. If it is, we are sure that this is TIA, or we have high index of suspicion that this is TIA, we will give 300 milligram of aspirin orally and immediately, unless the patient is having bleeding tendency or bleeding disorder, or the patient is or an anticoagulation, or the patient has already took his low dose aspirin dose regularly, or the aspirin, of course, is contraindicated. Do not use any scoring system, because in the past you may find in some of the books or some in the literature, the ABCD, or even up to date now, the ABCD score. It's not used anymore, or it will not change a lot in our management. If we are suspecting TIA, we will refer the patient to emergency department. So again, that's the same. Like if the patient has had the suspected TIA in the last few days and has not presented to the clinic immediately, it means like within the last week, for example, he had this TIA. Or before the week, for example, and he presented with symptoms typical of TIA, we will refer the patient to the emergency room if within the last 1 week. If more than that, we have to refer him fast for an assessment and CT scan and all of these things. If again you are having high index of suspicion, not sure, refer to emergency. Otherwise, you can refer urgent referral for OPD. And advise the patient not to drive if he's coming with like like 1 week or less than that, or TIA symptoms, until he goes to a specialist and get the diagnosis. This is a scenario of a 33-year-old healthy lady presented with right-sided upper and lower limb weakness since few hours. So on further history, we found that she's on oral contraceptive pills. The reason I added this scenario is just to keep in mind that in females who are in childbearing age, don't forget to ask about medications, specifically oral contraceptive pills, whether orally, whether patches, whether subdermal, devices. So ask about the oral contraceptive methods that they are on, because they will increase the risk of many medical issues, including cardiovascular diseases or CVAs, or, for example, TIAs. There are special situations that we should keep in mind. Is the hypertension, reduced blood pressure with caution. If the patient is having high blood pressure and symptoms of TIA and stroke, we will not give anything for blood pressure reduction. We will refer the patient. If there is arrhythmia, the patient is prone to more TIAs or more strokes. And if the patient is a female in childbearing age, think of contraception. So this is the Rosier score, which is a score used to confirm the diagnosis of a stroke. Of course, there are some points that will make a plus point or a negative point, and you can refer to once you want to confirm your diagnosis. So this is like a summary of what we have mentioned, and this is another summary just to keep you familiar with this poster. We have Hamid is a 3-year-old child brought by his scared parent to the clinic due to convulsion that started 3 minutes ago and is still not aborted. So his saturation was 91, his pulse was 100, his respiratory rate was 16, he is febrile with a temperature of 38.5, and random blood sugar was normal. So as you can know that he's having a seizure and he's febrile, so most probably this is a febrile convulsion. So we should manage this case as a febrile convulsion. And as you can see, it started 3 minutes ago, and you saw the patient. I just want to have a scenario. It's like an ideal scenario, but in real life, if the patient's house is just nearby the hospital, the clinic, and they will bring their patient once they have the attack, they will get frightened, they will carry their child, and they bring him to the emergency, I think mainly the 5 minutes will pass. So, and they will not be sure when exactly it started. So consider as if the 5 minutes, unless they are 100% sure that the 5 minutes has not passed, consider that the 5 minutes has already passed and start the management. Why we are postponing the starting of the management? Because it may abort by itself. So we will see the symptoms, if the patient is conscious, unconscious, what type of seizure, is it generalized or focal. We will take approach to the management and start medication by, of course, not forget to connect the patient to oxygen and check the blood sugar, because it is a correctable reason for a convulsion. Then we will start the management with, of course, rectal diazepam if the 5 minutes passed. and we will wait and repeat the diazepam up to 3 times every 15 minutes if required until the ambulance arrive, and those are the dosage for each age group. Of course, it's not preferred to give more than that because it may cause respiratory depression. Again, if the ambulance arrive and the patient is still seizing, take the Valium with you or the diazepam and go with the patient throughout the transfer, because you never know when you will need it. And also keep the patient on oxygen. Be ready for any arrest, la samhallah, and just be ready for the worst scenario. So there are special situations like antibiotic. So if we have a patient with febrile convulsion and we can give now antibiotic or anticonvulsant, which one is first? Of course, the anticonvulsant is first. Then we will reduce the temperature, because evidence showed that the febrile convulsion is not happening because of the very high fever or the very high temperature. It happened because of the surge, the fast increase of the temperature that happened and affecting and causing the convulsion, stimulating the convulsion. We have to think of, is it the first attack or it's a recurrent attack? So the advice will be different, the management will be different later on. If it is a status epilepticus and a non-epileptic, non-febrile convulsion, think of other differential diagnoses. This is also another beautiful picture from Palestine. So let's test our knowledge. So I don't know if you can, I'll read it, or will poll organizers?
Poll is ready, doctor.
Poll is ready. Okay, let's go then.
You can ask the questions, doctor, and ask
Okay.
participants
So
to poll.
what is the most appropriate initial management step for a patient with severe high blood pressure reading above 180/120 after taking brief history? A, take the patient to the emergency room and call ambulance. Take the patient to quiet room and measure the blood pressure again. Give the patient an oral captopril, 12.5 milligram tablet, or order a urine dipstick testing and ECG. You can answer, please. لازم نخلص بسرعة. We have to finish fast because we have 4 minutes and I have, I think, 9 questions. So if you want all the questions, choose fast. Okay, so excellent. 73% got the answer correctly, which is take the patient to a quiet room and measure the blood pressure again. As we mentioned, don't underestimate this step. It's very important and it may reduce it by 10 to 20 millimeter mercury. Okay, the second question, for a non-hypertensive patient who is coming with hypertensive urgency and confirmed blood pressure of more than 180/120, you should start a long-acting antihypertensive medication, give captopril 12.5 and recheck blood pressure. If reduced, then you can send the patient home. Follow up the patient next day without giving any medication. Do home monitoring for 4 to 7 days to confirm the diagnosis of hypertension. Let's get the answer. Start a long-acting antihypertensive medication. Excellent. Thank you so much. So كلكم معي. اللي قالوا give the captopril, just again, it's not wrong to give the captopril, but again, the preferred option, and we are saying the most appropriate answer we need here is to start the long-acting antihypertensive medication. It's the best and the better regimen. A 60-year-old lady known to have diabetes and hypertension presented with blood pressure of 190/120 confirmed reading and with atypical chest pain since 10 minutes. The first most appropriate management after taking the patient to the emergency room is to give captopril 12.5 milligrams stat, to give GTN sublingual tablet and aspirin 300 milligram chewable, do an ECG, call ambulance and refer without giving anything since the patient is having hypertensive emergency. Okay. Okay, so when give GTN and do ECG. Okay, of course it's right to do to do the ECG, but while giving the ECG or while giving the order of giving it, because you know it will take time fixing the ECG device or the ECG electrodes على the patient. But so give the GTN and give the aspirin 300 milligram chewable. Some people will get reluctant on giving the GTN without knowing if it is inferior MI or not. At least give the aspirin until the ECG is ready, then you will give the GTN later. But of course, starting management is very important in this stage. In a patient with a myocardial infarction, the chest pain can be best managed by GTN sublingually, can be repeated 3 times, 5 minutes apart, if not contraindicated. IV or IM morphine 5 to 10 milligram as first line step, since it will reduce anxiety too. Pethidine IV if GTN is contraindicated. All of the above are true. Okay. Okay. So GTN sublingual tablets and repeated 3 times is the best answer. And as we all mentioned, that morphine should be given if there is contraindication, or those 3 GTN tablet was three times given and with no response. And pethidine has no role at all in managing acute coronary syndrome pain. It has no role. I have searched a lot in the literature, and I haven't found anything mentioning that pethidine can be given as management of the pain for MI or chest pain and acute coronary syndrome. Okay. An 18-year-old young man
Sara,
talking.
sorry for interrupting you. We have 5 minutes.
5 minutes, excellent. Inshallah, نخلص on time. 18-year-old young man talking in full sentences, presented with wheezy chest, short saturation of 94, heart rate of 84 per minute, and he is on serotype evohaler. What is the most appropriate next step? Give 100% oxygen, nebulize ipratropium bromide, prednisolone 20 mg due to his age, up to 10 puffs of salbutamol through a spacer. Okay. So excellent, up to 10 puffs of salbutamol throughout a spacer. So we should give a treatment now. The saturation is fine, it's 94, fair enough. It will be better with the nebulization, or with the inhalation, I mean. Nebulize the ipratropium bromide, still we should give the salbutamol first. So the answer is D, up to 10 puffs of salbutamol through a spacer. And he is in full sentences talking, so he is not having severe, he's in moderate exacerbation, and he will improve with the salbutamol alone maybe, or we may give another dose of salbutamol later. And also introduction of corticosteroid should be early, but the dose of this answer was not correct. A 29-year-old pregnant lady presented with mild asthma exacerbation for the second time in 2 weeks. She quickly improved with nebulized salbutamol given in the clinic last time. She currently only using salbutamol inhaler when required. What is the most appropriate course of action? Add inhaled ipratropium bromide 500 microgram. Suggest she used salbutamol every 6 hours. Add inhaled salmeterol. Add inhaled beclomethasone 200 microgram BD. Okay. Excellent. So we will start this patient on long-acting, on inhaled corticosteroid. The take-home message of this question is that a pregnant lady should be dealt with as if she is non-pregnant in cases of asthma exacerbation or management of asthma during pregnancy, because the risk of the medications, the risk of complications of asthma outweighs any risk of the medication side effects. A 30-year-old gentleman who was previously healthy and not on any medication presented with symptoms of anaphylaxis. If the patient is not having a good response to epinephrine first dose, what is the next appropriate step? Send the patient by ambulance to the emergency department for further management. Give another dose of epinephrine after 5 minutes. Give hydrocortisone injection IM 200 milligram. Wait for a response, since the epinephrine will take more than 15 minutes to start action. Okay. Excellent. So we will give another dose of epinephrine, as we mentioned. We'll give first, second, then third dose of epinephrine before continuously, and the response will be very fast, should be very fast. The window time for thrombolytic therapy for ischemic stroke or TIA by TPA treatment is هذا عاد سريع السؤال. Less than 24 hours, less than 4.5 hours, less than 48 hours, or less than 2.5 hours. Okay, the answer. Excellent. So it's less than 4.5 hours. So it's very important in the referral letter to mention when the patient presented with those symptoms, because it may affect the management in the secondary care and sending the patient to the further management of thrombolysis. Okay. آخر سؤال, I think. Last question. So if a TIA is suspected in a patient with symptoms within the last 24 hours, the first management step is 300 milligram aspirin with PPI if not contraindicated, reassurance and advice to seek medical advice if symptoms recur, refer directly to emergency room in hospital without treatment since symptoms resolved at presentation, hold aspirin until CT scan is done to rule out hemorrhagic stroke. Okay, and the answer is excellent. So we'll give the 300 milligram aspirin with PPI if not contraindicated, because it's the treatment of choice and the patient is definitely having a TIA. هذا راح أطوفه خلاص. Thank you so much. And this is the beautiful Gaza. Before, inshallah, we should all pray for this beautiful country to come back to its original people. يعني نقول يلا إن شاء الله في الأيام الفضيلة. Thank you so much.
Thank you so much, Dr. Sara, for informative lecture. We have many questions. Residents in ER rotation. He asked in ER rotation, they do not do anything